All right, we are back for our final speaker of the day. We have Dr. Shandra, and Dr. Shandra is a University of Washington Associate Professor of Emergency Medicine and practices emergency medicine at Harborview Medical Center and the University of Washington Medical Center. And she actually just came over from the ER, so we're glad that she was able to make it. She's earned her MD from the University of Washington School of Medicine, and her MPH is from Harvard University. She completed her residency training in emergency medicine at Stanford. And Dr. Shandra focuses on medical education and co-directs the medical student clerkship in emergency medicine at the University School of Medicine. In addition to her focus on medical education, she conducts research on teamwork and communication in medicine and on injury prevention efforts. Dr. Shandra is a fellow of the American College of Emergency Physicians and is a board certified in emergency medicine. She was named top doctor by Seattle Met magazine in 2014, and she's going to talk to us about emergency stabilization for pediatric TBI. Dr. Shandra?
We'll get this started here. Oh, not that one, the other one. All right, now we're going. Hi, everybody from all over the place. Thanks for having me. Sounds like it's been a great webinar all day. I'm kind of going back to the beginning, and my apologies if it's a little extra medical today, but the thing I'm going to focus on is emergency assessment and stabilization of pediatric TBI. Again, I come at this from the angle of the emergency department and also working closely with pre-hospital providers. And one of the things I do a lot is see people with head injuries, and the question is what to do about them. So why is this important? I think you probably talked about this all day, but I think it's really important to think about how traumatic brain injury is the leading cause of pediatric trauma, death, and disability worldwide. And specifically that in our worst traumas that we see at this trauma center and at trauma centers around the country and the world, for kids, often the most significant involve these TBIs. So today I'm going to identify some common emergent presentations and causes of pediatric traumatic brain injury. I'd also like to demonstrate the use of clinical decision rules to identify criteria that warrant imaging in more minor traumatic brain injury in children, which is more common. And then also sort of describe the key considerations in emergent initial stabilization of more moderate to severe pediatric TBI. So some common causes of TBI are those that you would expect. The two most common causes listed are motor vehicle crashes and falls. And these can be all types of falls. Motor vehicle crashes, often more risk when there's not wearing seatbelts. Unrestrained children have a higher risk. We also have kids with injuries from bicycle crashes, pedestrian versus auto, and particularly doing activities without wearing helmets. So common things being common, we see a lot of them. And I always like to frame thinking about evaluation of these injuries with cases. So I'll give you my first case. I have an 11-year-old male who was an unhelmeted skateboarder. Many skateboarders don't wear helmets. Who was skating around. He jumped off his ramp, went up about 5 to 6 feet, and he fell onto cement. He had a brief loss of consciousness. And he came in with a heart rate of 98, blood pressure of 110/82, respiratory rate of 16, and an oxygen saturation of 99%. All of these are nice and normal. He was alert, oriented, and amnestic to a brief event. So he didn't really remember what had happened during that event, but otherwise had a very normal neurologic exam. So very examinable, and his ABCs, which is airway, breathing, and circulation, were all stable. So my question to you all, you get to raise your hand at your own computer for yourself, is does this child need a CT of the head? And these are the questions that clinicians face both in offices and urgent cares and emergency departments every day. Do we need to do something about this? Do we need to look further? We kind of want to be careful with radiation in kids, right? We know that there are some risks to the exposure of radiation, of doing a CT scan. There are costs to doing that. And there's a general principle when we look at imaging children called ALARA, which is as low as reasonably achievable, which basically means that we try to do the minimum amount of radiation necessary to do the appropriate care for kids. So for many reasons, we try to be really judicious about choosing when to image and when not to image. So one of the things that we have, thankfully, are some clinical decision rules. So the PECARN is an emergency care research network. So it's a group of hospitals across the US and Canada that looked at this very question. They said, if we have a whole bunch of kids and a whole bunch of cases, is there a clinical decision rule we could make that would help us make reasonable, rational, and safe decisions for kids when they come in with closed head injury? So it's a derived and validated clinical decision rule. So they had all these centers and all these kids. We had greater than 30,000 children in the derivation study, and they had greater than 3,000 in the validation study. And what they were looking for is which kids would we find clinically important traumatic brain injury? It's all clinically important, as if you've heard. But in this case, what we're saying is if we find something on a CT scan that would make a difference for their management. And what they define those as death from traumatic brain injury, neurosurgical intervention, intubation for more than 24 hours, so needing to be on a breathing machine for that long, or admission 2 or more nights. And with this rule that they developed, which I'm going to talk about, they had a CT scan rate of approximately 35%. So it's all kids who come in at baseline having signs or symptoms of a traumatic brain injury. What was helpful about this is they sort of broke it down by age because they found that small children have different things than bigger kids. So the top boxes here are actually about children that are less than 2 years of age. So sort of pre-verbal children. I need to move something to be able to see my slide. So they, if you start at the beginning, it's box A. We look at, this is for kids under 2. Do they have an abnormal GCS, which is a Glasgow Coma score? So is their neurologic exam abnormal, or do they have signs and symptoms of a palpable skull fracture? Can you feel something? For those kids, it's pretty straightforward. When you have somebody present like that, we need to get a CT scan. So that's yes, and you go over to getting a CT scan. If that's not the case, so not an abnormal neurologic exam and no signs of a palpable skull fracture, we come down here to box 2. Then you look at the child and you say, okay, do they have an occipital, which is back here, or a parietal or a temporal scalp hematoma? So anywhere around here, but not the front. So anything but your forehead, and a hematoma is like a big bump. Do they have a history of loss of consciousness for greater than 5 seconds? Or do they have a severe mechanism of injury? Also, are they not acting normally per parent? So these are all the sort of intermediate risk factors. If they have any of those, we go over into this intermediate box where we say, well, we could get a CT scan or we could observe them. Because what we know is that this group of children has a 0.9% risk of clinically important traumatic brain injury. So really pretty low risk, but it's there. And so how this usually goes is a discussion with the family. And the question is, does the physician feel like this child is more likely to have a head injury, a more severe TBI? Are there multiple of these things? So, say they have the hematoma, plus they had loss of consciousness, plus it was a really severe mechanism of injury, and they're not acting normally, I'd probably CT that child and talk to the family about it. Or do they just have one of them and they look great? Another reason that we might decide to image at this point is if their symptoms worsen, or if they're really young. Those infants less than 3 months are really hard and have really fragile skulls. So it's often really hard to get a good exam on those. And sometimes if the mechanism and the circumstances are sort of concerning, it's more prudent to image at that case. Then there's also parental preference. Some parents feel like they can't possibly go home without knowing for sure that there's not something on the CT scan, and other parents feel more comfortable observing. If they have none of those things, this no box, this is the best, I really like this when patients come in with this, then CT is not recommended. So we can tell the parents that they have less than a 0.02% chance of having anything that might be clinically really significant. And even those clinically significant things where we find a bleed, most of the time they do fine and go home, fairly soon. They do fine, at least from the emergent part of things. So when what this rule is really helpful for is when all those things are no, when they all look okay. And then we can say, hey, I think everything looks good. We can probably avoid doing this radiation right now, as long as you're watching your child closely. The boxes down below are for the older children. So these are for children ages 2 and above. So kids who can start talking to us. And this is the same thing where the first question is, do they have anything less than a normal GCS? So the best Glasgow Coma score you can get is a 15. So if you have 15, you're normal, and I will talk about that a little bit later. So anything less than normal, then they need to, or they're altered, then they need to get a CT scan. If they have signs of basilar skull fracture, which would be sort of bruising back here, a bunch of bruising around here, leaking fluid, something that makes us really concerned about a fracture, then those people we would get a head CT on. Even those have a 4% risk. So even in all those patients who have really concerning findings, it's pretty low risk of a clinically important TBI, but those ones we get a scan on. If they don't have that, then we go to the intermediate question. And for these kids who are older, so 2 and up, did they lose consciousness? Did they vomit? Did they have a severe mechanism of injury? Or are they complaining of a severe headache? If they have those things, then we go to that observation versus CT scan again. And again, it's sort of a similar discussion based on everything else. If they don't have any of those, didn't lose consciousness, not vomiting, no severe mechanism, no severe headache, then we can, talk to the family and we can say, the CT is really not recommended. You have less than a 0.05% risk of having, something significant on the CT scan. And given the fact that your child looks great right now, even the findings would be less concerning in terms of the radiation risk. So this helps us guide the management for minor TBI. Oops, let me go ahead. This is another way to look at it. Thank you, California ACEP, for having this nice slide. I like this one as well, just because it sort of lays it out for you. So if you were to see a patient, so we're going back to our 11-year-old. We have this skateboarder, right? So we say, here's the skateboarder. He comes in looking great, but he had jumped 5 to 6 feet, and he had a brief loss of consciousness. So GCS is not less than 15. He's okay. He does not have signs of basilar skull fracture. He doesn't have any AMS or altered mental status. So we say no to these. He's not vomiting. He did have loss of consciousness. He does not have a severe headache, but he did potentially have a severe mechanism of injury. He fell from greater than 5 feet. These are the mechanism ones we talked about. MVA's motor vehicle accident with ejection rollover fatality. He was not a bike or pedestrian versus a vehicle without a helmet, and he wasn't struck by a high impact object. So this kid had these two. He had a loss of consciousness and potentially a severe mechanism of injury. So he goes into yes to any in terms of observation versus CT using shared decision making. What we ultimately decided with this child, together with his parents, is to watch him. So we watched him in the emergency department for several hours. His symptoms never got worse. He felt fine. And after discussion, we decided that he could go home safely with observation with his family, with good follow-up with his primary care provider to discuss those return to play things that Dr. Herring had talked about. So that's one case. Case 2. Now we have a 15-month-old female. So now we're going in the under the 2 years of age child. This child was dropped by the 8-year-old sister onto a wood floor, not on purpose, but 8-year-olds happen. Had less than 5-second loss of consciousness. So did have a loss of consciousness, very brief. Came into the emergency department with normal vital signs, a normal neurologic exam, and had a small hematoma over her forehead. Otherwise, normal exam and reassuring family interactions. And so the question is, again, ask yourself for a moment, does this child need a CT of the head? And I know what you want now. You want this, right? So you say, okay, for children younger than 2 years, what do we do? So we look at step 1 and we say the GCS is not less than 15, which means her neurologic exam, everything about that was normal. We also didn't feel any palpable skull fracture, and she's not altered. So we get to go to no here. Then we go to the intermediate risk things and we say, scalp hematoma. Yeah, she had one, but it says excluding frontal. And she had a little frontal hematoma. And of all the places that children get hematomas or goose eggs, the forehead is actually the most reassuring. I often tell patients and families that this is sort of your bumper. These areas are thinner and more concerning, and these ones not as concerning if everything else looks okay. So she had a scalp hematoma, but it was frontal, so that doesn't count. She had a loss of consciousness, but it was less than 5 seconds, so that's okay. She was acting normally per parent, and she did not have a severe mechanism of injury. Her 8-year-old sister was not tall enough to drop her 3 feet, and she was doing just fine in terms of that. So she actually goes into this category. This little one went into the category of CT is not indicated and observe. And we were able to talk to her parents about this low risk, this 0.02% risk of having a clinically important TBI. And we watched her in the emergency department for a while, and they continued watching at home with close return precautions. So in this sense, these clinical decision rules can be really helpful in sorting out the initial imaging of somebody with a minor TBI. Here's just one other illustration of the same thing. So another way to look at this, just because I know everybody has different ways of liking to interpret and look at these algorithms. This is the less than 2-year-old versus the greater than 2-year-old. That first thing is pretty much the same. Is their GCS normal? There's something concerning about a skull fracture, are they altered? And if those things are true, you get a CT. The additional findings are over here, and then those severe mechanisms. And then you say, okay, if they have some of those additional findings, you observe. If they have none of them, you get to DC or go home. So again, in minor TBI, those patients who present with a normal GCS initially and a pretty milder injuries, the clinical decision rules are really important in determining the extent of our emergent evaluation. With those, we have to make sure that there's really close return precautions, because no rule is perfect. We have to kind of put it in the context of the individual patient and their family. But generally speaking, we can give them close return precautions and then close follow-up, because we know that even the mild TBIs do need important follow-ups for return to play, return to school. And so they need to make sure that they get to follow up with somebody who will reassess them. So now we're going to move to a little more of a serious case. Case 3, I have a 3-year-old female who fell from a second-story window. This happens in Seattle because we don't have air conditioning, and when it gets warm, people open their windows, and kids fall every year. We're working on this. This little one fell out of a second-story window and landed on the deck. The initial assessment at scene was her heart rate was 112, her blood pressure was 112/78, respirations of 20, and oxygen saturation of 98%. Her initial neurologic exam was her eyes were closed, and she was moaning, and she was withdrawing to pain. So the question with this is, where do we start? With trauma evaluations, we always do something called the primary survey. So the primary survey of trauma is an ABCDE, and it's a rapid assessment to immediately recognize and intervene on life-threatening injuries. What I'd like to do is sort of walk through the primary survey, and I'm going to highlight things we consider with more severe TBI, emergent considerations of TBI in the primary survey of a trauma evaluation. So A is for airway. And airway considerations with TBI include, who do we intubate? Who do we put a breathing tube in so we can give them as much oxygen as possible? We can make sure that they are maximally treated and maximally secured to help protect their brain. So if somebody is unable to protect their airway, which usually means that they're very altered, maybe they have a lot of facial trauma, then we might need to put a breathing tube in. If their GCS, Glasgow Coma Score, is rapidly declining, so their mental status is rapidly declining, or a GCS generally that's less than or even equal to 8, that's when we often consider intubating to really protect their airway, make sure they don't have additional damages of aspiration or risk of not having enough oxygen. Our goal with that is to maintain normal capnia, which means we want to keep their CO2 level the right level, and we also want to avoid hypoxia and additional insults. This is one of my favorite slides, and I think about this because it's, you think about ballerinas, right? These little ballerinas, the little toddler ballerinas, they put their arms up, and their arms touch right here, right? And then you get older and adults and bigger children, and your arms go way up here, and it just sort of illustrates how big the heads are relatively to the bodies of little kids versus bigger kids and adults. And this is sort of, it's something that fits into the TBI thing in general. Little kids have big heads. It puts them at risk of head injury, but it also makes a difference in terms of how we position them and how we manage their airways. And so, for our pre-hospital providers, one of the things that's big with these kids with the little kids with big heads is if a baby lays down or a toddler lays down, their big head, if you lay them flat, actually sort of nods. And so little babies, you can see how his chin is sort of going up towards his chest. We actually want to make sure that their airway, which is back here, their trachea, is nice and open. So the positioning of small children with TBIs and children with trauma in general needs to be a little bit adjusted. So we often put padding under their shoulders. We don't want to hyperextend their neck, but we want their neck to be in a nice alignment. So those big heads make a difference in a lot of ways, and it makes a difference in terms of when we're thinking about managing their airway. In this case, our 3-year-old was not really protecting her airway in a way that made us feel comfortable, and so we gave her we intubated her and put an endotracheal tube in to give her oxygen, and then we decided we needed to move to B, which is breathing. And as we move into breathing, generally things about breathing in kids we think about a lot is, little kids often have a very pliable rib cage. So, they're more like sharks. They're made of more of cartilage. So they have very bouncy rib cages. And unlike adults where you can feel the rib fracture sometimes they've had pretty big bruises to their lungs, and the rib cage doesn't show a lot externally, especially when you fall from a second floor, you have those more severe mechanisms. More likely, these kids will end up with contusions or bruises in their lungs, and so they'll often need extra breathing support. And so, for kids with traumatic brain injury, we want to really maximize their oxygenation and their ventilation. One of the key take homes we talk about with our residents and our pre hospital providers is really aiming for a normal CO2 for them. So, a CO2 in the 35 to 40 range. We don't want to routinely hyperventilate them. And we also want to make sure that they get adequate ventilation, so some more sort of normal. We also want to avoid hypoxia because that's secondary insult to this brain that's already hurt. So we try to avoid that. So giving them high flow oxygen with intubation or whatever else they need is really helpful. So we go back to our 3-year-old for breathing, and we listen, and she's got bilateral symmetric breath sounds. There's no crepitus, so nothing that we feel like is abnormal, and no bruising. We get a chest X-ray, and we kind of move on and say, okay, breathing's okay now too. And with these ABCs, we keep going through them and make sure that they're doing okay. So A's and B's were okay, and we moved into C for circulation. And circulation is where we sort of think about, is there bleeding that we need to stop? Do we need to give them more fluid to bring up their blood pressure? Is there any other consideration that we can do for that? With pediatric patients in general with trauma, they have sort of a lower total blood volume than adults do. So we really think about how much blood they can lose. And if you have a head injury with scalp lacerations, as you've probably seen in your lives, they can bleed a lot. So especially because they do bleed a lot externally, we want to make sure that we keep an eye on that. Or if they have other injuries, say their spleen is injured or their liver is injured, they don't have a lot of blood volume to lose. They have pretty vulnerable internal organs. They've got sort of thinner, less muscular abdominal walls. So with the bigger traumas, we worry about intra-abdominal injuries. And like we talked about, have a flexible rib cage. Something that we have to think about a lot is the fact that blood pressures are different for different ages. And it's helpful to have a resource near you to get a sense of, is this a blood pressure and a heart rate that's normal for this age of child? So there are many different charts one can use, but this is sort of just one of the many about pediatric vital signs showing that it ranges, right? So when they're little, having a heart rate of 140, 150 is totally okay. And you can have a systolic blood pressure of 65, and that feels all right. But a 5-year-old should not have a blood pressure of 65, and certainly a 12-year-old should not have a blood pressure of 65. And so having access to what we expect normal vital signs to be can help us assess the circulation for children and maximize how they're doing to be able to protect them and to protect their brain with a TBI. We also look for signs of shock. So early signs of shock in children with trauma include, well, children in general include delayed capillary refill. You press on your finger, see when it gets pink. Greater than 2 seconds is delayed, which shows us maybe they're not perfusing quite as well. They can get mottled skin. Their heart rate starts going up first. Then their blood pressure starts having a narrowed pulse pressure, so the systolic over the diastolic narrows. And then they can start having a decreased level of consciousness if they're not perfusing very well. Once kids become hypotensive, it's actually a late sign that it's shock. So we're pretty concerned when we have a pediatric patient with hypotension, especially with the TBI. If we have a hypotensive patient, we really need to work on their resuscitation and on their circulation to be able to protect them and protect their brain. We have additional resources to help care for kids, such as the Broselow tape. I'm sure many of you have seen this, but it's a nice way to estimate a child's size and weight based upon their height. You put the top of the tape on the head, red to head, and you measure down to where their heels are, and then it'll give you one of these colors. And with those colors, you can have an estimate of the weight. And What's great about it is on the back of this tape, you can have all the different medications you might need. So considerations for resuscitation medications, for intubation medications, and otherwise. So those are helpful. We find them useful both in the pre-hospital and the emergency department world. So we can have, oftentimes our paramedics will bring in patients, tell us what Broselow color they are, and we can have things ready. And especially in the more severe injuries, it's helpful to be as ready as you can and try to get the right size equipment ready, because there's a whole variety of sizes. So getting those things ready makes a big difference. So in terms of what we think about specifically, I sort of touched on it, but I wanted to call them out, is we really want to try to avoid hypotension. We also want to try to avoid over resuscitation. So we try not to give them so much fluid that they have too much fluid in their intravascular volumes, because that can lead to cerebral edema. So we try to get just the right amount, not too much. It's Goldilocks. We got to get just right. And then we also want to correct coagulopathies. So sometimes with trauma patients, they can end up having problems with their coagulation, and sort of correcting those so as not to worsen them is important. After circulation, we go on to disability. Disability is, we think about the neurologic exam, potential spinal cord injuries. Speaking of spinal cord injuries, with Airway, we always want to make sure we protect their cervical spine until we sort out what's happening with their brain. But that's just a given. Just want to put it in there. Disability, we sort of look for any signs of head trauma and what is the neurologic exam. So our 3-year-old had some obvious head trauma, had periorbital ecchymoses, so bruising around the eyes bilaterally, and the eyes were closed. She was moaning and she was withdrawing to pain. And here's where we could calculate her GCS, so the Glasgow Coma Score. The adult one is listed down this line, and the GCS for children is down here. So she did not open her eyes, so there's none here. If verbal response was moaning, so she got 3. So she gets 1 point for eyes not opening, 3 points for moaning, and she withdraws to pain, which is 4. So she had a GCS of 8. The GCS goes from 3 to 15. Even the most unresponsive person is 3. So a GCS of 8 is pretty significant, and concerning, again, why we intubated to give her airway protection. Also helps to sort of put it in context of the severity of TBI. So a mild TBI is a GCS score of 13 to 15, moderate is 9 to 12, and severe is less than 9. GCS is something that is most helpful when we follow it over time. So sometimes somebody will be evaluated right after they have loss of consciousness and be pretty out of it, maybe a GCS of 11 or 12, and by the time they get to us, they've got a GCS of 15. Other times they started a GCS of 14 and they go down to a GCS of 9, and that evolution is actually important. So nobody is one examination GCS, they are a GCS over the time. So in terms of the general considerations that we've talked about, large heads are at risk of injury. You can always think about ballerinas, and the majority of our fatal pediatric traumas do have this head injury. When we think about taking care of them, we want to avoid hypotension and hypothermia. So we also want to keep them warm, but not too warm. They want the right temperature. It's all Goldilocks. We want to be just right. We want to keep their end tidal CO2 normal, so 35 to 40. We want to protect their C-spine. Also want to keep the head of the bed elevated. And then other things that we think about all the time are, when do we consult neurosurgery, and what do we do if there's signs of herniation? And herniation is, of course, the worst case that we see. When there's signs of this, patients they can develop changes in their vital signs, so they could become hypertensive and bradycardic. They also can have changes in pupils. So somebody comes in and one pupil starts getting bigger than the other. That's a sign that there's a lot of pressure going on inside. They can have abnormal respirations, and they can do posturing, which is a sign that there's of your body also having too much pressure inside your cranium. So things we do, if we see those signs, immediately elevated the head of the bed, call neurosurgery, or transfer to somewhere with neurosurgery, depending on where you are. We could use osmotic agents to help try to take some of the fluid out and decrease the pressure. So either mannitol or 3% normal saline. And there's a limited role of hyperventilation. In the lore, there's always been a lot of hyperventilation for brain injuries, but we do know that routine hyperventilation leads to worse outcomes. So we limit hyperventilation to only those patients who have impending herniation, where we need to do something emergently. Couple of pictures, because I think it's important. This is the neurosurgical indications for this, and I'm almost done. Include this one's a subdural hematoma, so you'll see a crescent-shaped bleed over here. The next one is called an epidural hematoma, so you'll see a bleed that's shaped more like a lens. Both of those involve neurosurgery. The epidurals typically will go to the operating room, not always, but many times. And subdurals are often watched. It depends how big they are. This is subarachnoid hemorrhage, so around the brain. Most of the time, these need to be observed. It depends. There's also air in here, which indicates a fracture somewhere. And then this one is a contusion, so bruising in the brain. These ones are all more severe TBIs, but findings that we look for and communicate with our neurosurgical colleagues. Our 3-year-old ended up having bilateral epidural and subdural hematomas. She also had a laceration to her spleen and some facial fractures. Ultimately, actually did great. She got extubated after 12 hours. She did not need surgery, and she was discharged 2 days later. And 2-month follow-up back to regular health. And something that always makes me feel better is thinking about the fact that kids really do have great healing capacity when given the means, that oftentimes they can recover from things that are really severe better than adults can, although still needed a whole team and needed a whole lot of extra work later. So my recap on primary survey with TBI is thinking about airway stuff, that we intubate if the patient is rapidly declining or having respiratory or ventilatory compromise. For breathing, we aim for normal capnia with a CO2 of 35 to 40, and we avoid hypoxia. With circulation, we avoid hypotension and overhydration. With disability, thinking about things like our clinical decision rules are helpful in determining imaging for minor TBI. We want to avoid hypothermia in addition to hypotension. We want to reassess frequently, that GCS needs to be rechecked. And we talked briefly about considerations if the patient begins to herniate. And the last thought is just, one of the other things we think about this in the big picture is thinking about why this happened for this patient. Was it an abuse situation? Was there some other thing going on that no matter what happens to the patient, we have to think about the big picture for them? And now I will take questions. All right. Somebody asked, in the absence of acute intracranial pathology or skull fracture on CT, do you have any helpful suggestions for physicians that may not be comfortable attaching the TBI diagnosis to a trauma patient and or treating that patient for TBI without actual physical evidence? That is a good question. I think the treating them is the part that I can answer the attaching the diagnosis question of that, which is that if they have a normal CT, I kind of think of this in the concussion spectrum. So I've become more comfortable talking with patients about it as a concussion. I think with more awareness of TBIs in general, patients and families are pretty open to this. And I say, if you hit your head significantly and came in with enough concerns that we got a CT scan, or even enough concerns that we assessed you and talked about why we were or were not getting a CT scan, I give them the diagnosis of closed head injury and give them concussion information and follow up. So I think that suggestions for people who may not be as comfortable with this and haven't dealt with it as much is really thinking about it in terms of increased awareness in general, saying that we know that little bumps to the head can be a big deal over time, and we just want to make sure that everything is okay. Potentially finding other people in your community who do this more often too. I mean, I think sometimes we have a traumatic brain injury clinic, and I refer there all the time because there's parts of this that I don't know about the follow-up, right? I send them there because I rely on others with that expertise. I think a lot of times those of us who deal with the first presentation of a head injury, our job is really to sort of assess, is this bad or not? And then make sure the family understands where they might need to go to follow up and think about the next steps. I hope that helps a little bit. I think a lot of times we don't think of physical evidence. And, one thing I didn't say about with the CT head was actually, most of the times we don't see any findings on the CT, right? But we did that CT because they hit their head. And so that fits into the closed head injury, mild TBI realm. I'm looking for other questions. Am I missing them? I guess another thing I could say while I'm just sitting and thinking about that is there are also some good patient handouts. And so another thing I would consider is looking into whichever resources you have for patient handouts about mild TBI and concussion. And if you have some of that available, it's helpful to give that to families to look at.
All right, we'll do one last call for any questions for Dr. Shandro. It looks like nothing else is coming in, so I guess people feel confident in what they've heard. So thank you very much. We appreciate it. Thank you for sharing with us today. If you have further questions, just let us know. We'll make sure they get further pushed on to the speakers, and we'll um, get back with you on those. All right. Well, should we go into closing? Yeah. So we'll go into our closing now. We just want to again thank all of our speakers that have been on today. We've heard a lot of great um, messaging, a lot of great information. And so these people are all resources for you wherever you're linking in from. We'd be happy to make sure that you get connected with those people to continue those conversations to do the work, this work on pediatric TBI. We do have, before everyone jumps off, we want to make sure that you have you take time to do the give us some feedback and take the survey for the evaluation on this. And so there is a link there. If you can make sure that you click on that link and do that survey, that'll help us make sure that we prepare for the next round of these webinars in the future, and let us know what your interests are related to TBI as well, and how we might be able to further connect with you on this topic. So I did want to kind of share with you just a little bit about where people connected in from. And so here's just the United States, and you can see the people that connected in with us to learn about this topic came from all over. We had a very nice coverage from that, and that just goes to show that this is really a problem that occurs all over the place. And from the topics that we had today, you can also, I think it also shows how much TBI really connects in with a lot of the injury areas that we work with in public health. And, we've heard about motor vehicles, we've heard about falls, we've heard about sports, and so there's really a lot of risk and protective factors that overlap here in regards to TBI. And so those are things I think we want to be aware of and see how we might be able to connect further in these other areas. So, but from our audience, we had 23 states represented, 316 registrants, and well over 100 different sites. And so we had some places where people were grouped together at those sites viewing. Our preliminary stats said that 46% came from Washington State, but that was only about half of our registrants. And so that was a little bit more spread out as we got through later on. And if you want to know those stats, let us know. We'll be happy to share that out. But we had people from California to New York, and as far away as London, Bulgaria, and Saudi Arabia. So we actually were able to go international with our presentations today, and I think that's good work that we can connect with all over to do this work. We had people, physicians, nurses, public health professionals, students, educators, school counselors, and even some family members that had children that have been affected by TBI wanting to get more information. So this is an issue that's important to a lot of people in a lot of places, and we can see that we have a lot of people that are working on this issue, and it's crossing multiple fields. And so we want to be able to facilitate those connections. We had a wide array of organizations such as Seattle Children's Hospital, University of Alabama at Birmingham, all the way down to first responders and such as Airlift Northwest and Burlington Fire Department. So a wide span of our of people looking at this topic. And so I wanted to share with everyone a little bit of history of this event, how we got this put on and what made it brought it to life. This was made possible through a CDC grant for the State Violence and Injury Prevention Program under the Regional Network Coordinating Organization component for national peer learning teams. And so we are putting together some out of the 5 regions across the United States, the regional networks, each area has a topic area, and so Washington State is leading up the TBI National Peer Learning Team. This is in development right now, and we're going to officially kick this off in September. But we want you to be able to connect in. So if you're doing work with TBI, or you have partners that are working with TBI, and you want to connect with other researchers and people that are working on TBI and concussion work as part of that National Peer Learning Team, you can contact us at the Washington State Department of Health, and I'm the contact person there on this project. And so Will.Hitchcock at doh.wa.gov. And just send me an email and let me know that you'd like to be a part of this and get more information and connect. And we'll get you on the communication distribution and make sure that you start getting information. And it may be that if you have some research or work that you have done that you would like to be able to share and present, we'd love to help you get that information out on this topic, and connect with me and let me know. For this event, we have a long-standing relationship with Washington State Department of Health and Harborview Injury Prevention and Research Center. We've done we do a lot of work together on injury and violence prevention work, and so this was a nice fit for us to be able to work together in partnership again. And we had just such an outstanding response for this session that we're already in the works for the next round and to do another one of these. And our plan is to look at adult TBIs and all the pieces that go with that. So be looking for that. And if you're part of the TBI National Peer Learning Team, you'll of course be getting that information as those programs and get developed and put out. And great resource for being able to connect and be able to disseminate your research and the work you're doing. And so connect with us, let us know how we can help with that. In order for people to utilize some of these great things that we heard today, we got to get that word out. And so that's our goal, is to be able to help participate and do those things. So some final announcements. A recording of this, the webinars from today were all recorded, and they are going to be available in a week on Harborview's website. And so you can see the link there on your screen. You can go there now and save that page and be able to come back to that later. You should get an email, though, that will, if you registered, and that will let you know that the recording is posted. And you can also follow Harborview Injury Prevention Research Center on Facebook and Twitter at HIPRC for any further updates and other information on this topic and a number of other areas that they're working on injury prevention. Many of you were interested in the C&E credits. You can still earn C&E credit for attending today's webinar. There is a link there on the screen that you can go to and for the registration. And then you can also learn more or email cne@uw.edu or call 206-543-1047. There is an administrative fee of $45, but the rest of the credits were covered as part of this program. So we hope that you will check that out. I'm going to check our chat window real quick and see if there's anything else in here. Any other questions? And we did put the survey URL in chat, so you can copy and paste that as well. And make sure if you are doing the CNA credit that you did get the, that you do the evaluation. That will be a required part of it, and that was posted in chat as well. And definitely give us any feedback that you have on the sessions, whether good or bad. We want to be able to expand this and make this even better next time. So let us know how we did. Let us know what worked, what didn't work for you, and we'll see how we can be able to address those things for the next round. All right, so I think that will bring us to a close. Thank you guys for all participating with us and being a part of it. We will see you next time. Thanks. Bye.